the agenda tonight is that Jacqueline is going to go through the importance of research to the IKA, and then looking at a patient-led approach to research. And then we break for questions. And then we'll have Dr. David Keane coming in to go through a specific research proposal that we've agreed to get involved in. And there'll be more time for questions. And then we'll go through next steps, and then we'll feedback on the meeting. Okay. So just to give it a bit of context, Jacqueline is going to go into more detail, but we have a very big research strategy in our strategic document. We have a big piece around research, and we've actually joined a charity called the Health Research Charities Ireland, which is a national umbrella organisation of charities engaged in all different types of research, which represents over 2 million people in Ireland. And what they do is they champion our interests to make sure that the environment for health research in Ireland gets better, and that they basically help us to become better at research, because up to Health Research Charities Ireland coming on board, we were all doing things in our own little silos, whereas with HRCI, it means we get a lot of tools, a lot of resources, and we even get some money out of them, which is fantastic. So I'll talk a little bit about that in a minute. Our current research projects that we have underway that we are directly leading on is understanding patient experiences in the healthcare system. Some of you may have even participated in that, where we did questionnaires and we did focus groups, and that's going to be published in the hopefully early spring. And we did this in partnership with the National Renal Office. And this is going to be the very first academic quality standard of kidney patient experiences in the healthcare system. So we're really looking to put forward to publishing that. And just to mention, we will circulate the slides afterwards, so you don't have to take notes. Another big study we did, and again, this was important because by being a member of HRCI, we were able to apply to the Health Research Board, and they matched €100,000. So we got €100,000 out of them to do patient-reported outcome measures in glomerular disease, a specific type of kidney disease. And it's really important for us that we're looking at measures from a patient perspective, because what's important to a patient, the doctors may not realise. And already through these two studies, we've realised that itching is a big problem that isn't being addressed, where patients have a lot of skin itching. The other project that has been going on for a while is the Irish Kidney Gene Project with Professor Connellan in Beaumont Hospital, where we're trying to look at genetic causes of kidney disease. And then we also support various projects in Support Magazine, where we advertise, do people want to get involved? So every edition of Support Magazine would nearly have one call for people to get involved. So tonight, what we're about is understanding the burden of kidney disease in Ireland. And I'm going to hand over to Dr. Jacqueline Burke, who is leading on this. And we're very lucky to have her, because Jacqueline has a huge wealth of experience in this area. She's a general nurse. She was previously director of the UCD Graduate Diploma Nursing in Critical Care Cardiovascular Program. That's a mouthful in itself, isn't it? And she's currently the Emeritus Assistant Professor in UCD and Chair of the Pre-Hospital Emergency Care Council. So what this means is that Jacqueline understands the lingo. We all know when we go into doctors and into healthcare professionals, there's this whole language difficulty, and it can be sometimes very difficult to understand the terms and the language that's been going into it. And Jacqueline has recently joined the board of the IKA, and we're delighted that Cathriona Charles, another director of the IKA, is with us tonight as well. But most importantly, for many years, she was married to Martin, still married to him, but unfortunately he died recently. But he was a kidney patient. So Jacqueline really understands the journey that kidney patients go through, the ups and the downs. So this is where we really value having her on board, because she has all the lingo and the academic terminology, but she also understands on a lived experience, you know, what kidney patients go through. So she has that emotional connection. And this is why we're delighted to have her leading on this group. So I'm going to hand over to Jacqueline now, and stop sharing. And Jacqueline, hopefully the technology will work and you'll get to share your screens.
Carol is trying to share my slides. Thank God I sent them to you.
Yep.
Just thanks for the nice introduction, and we did discuss what we might put up there. But I guess what I really wanted to say in terms of all of that, I have no conflicts of interest in this. I've no skin in the game as such. I'm not doing any research into kidney disease, and I'm not part of any of the projects. So it is, I guess, important to get the background up there. And
yeah, sorry, it's just been slow to come up, but I think I have it now coming up.
Okay, that's great. And we can move on to the second one, I think, at this stage. And really, maybe we can move on as well, because the people here are in the know, but or maybe we'll go back just for the people that maybe we'll look at this afterwards, that just it is important that to know that we have our strategy, and that really, I guess, the big thing in our strategy is that patient remains the center of the IKA, and patients' needs are paramount. And so our mission is to be a national patient-led organisation that supports, educates and advocates for people living with kidney disease or end-stage kidney disease. And we've a vision to bring about the best quality of life for those with end-stage kidney disease and equality in their treatment and care. And we're guided, everything we do are guided by our values, which have been identified as being equality, innovation, volunteerism, which we're at tonight, quality and partnership. So then if we go to the next one, Karen. So you probably all are familiar with the 5 themes, overarching themes of our strategic objectives. And I just, at the center of it is supporting patients and their families. It's key, and it underpins everything that we do. But you can see then that one of our overarching themes there is researching, campaigning and advocacy. And so if we go into the next one, so the next slide. Our objectives in that our domain or overarching theme are to work towards improving patient care and experience. And I think the current study that we'll be looking at tonight certainly is doing that. And the current study will also help us with the next objective, which is to lobby for changes to policy and practice. And delivering patient-centered research is really important as well. So if we go to the next one, so my thoughts when I looked at our strategic aims and I thought about patient and public involvement, my thoughts are like that patient and public involvement in research helps to advocate that the research is meaningful to patients and helps them then to live well, which is another one of our overarching themes. And then this gives us data for our campaigning and advocacy. And I also, feel that this can be facilitated by having active and dynamic branches who give us the people that will become involved in the research. So if we go to the next one, Carol. So, we could spend a whole day on talking about research. And there's, Carol mentioned the Health Research Charities Ireland group. And there's also another group that really is supporting the third level institutions to support people who become involved in research as patients or public. So they're known as PPI Ignite. And they produced a document to help charities and researchers that want a partnership. And they defined research as an essential element of addressing unmet health and social care needs. And they also say that when a charity is involved as a partner in research, the charity and its community benefit from the generation of research evidence addressing questions that matter to them. So charities get involved in research is really important. And they also say that charities are often very well placed to ensure the relevance of research to patients and the public, and to benefit society to help society benefit from research. We'll go to the next one. I'm sorry if I'm not looking directly at the camera, it's probably, but at least you can see the slides. So so PPI is what we keep talking about, and that is patient and public involvement in research. And so what exactly do we mean by patient and public involvement? So we look at the word involvement first of all. So people in any research, people can be involved in research in three different ways outside the study team. So we can participate as a study subject or a study participant, and that's known as participation. You can also have people involved in research when public awareness is raised about a study, maybe in the newspapers or in magazines, or people are invited to information meetings or open days. And you actually need engagement to get people to participate as study subjects and to get people to be involved in research as collaborators. And that's what the last way of people getting involved in research is. It's involvement, and that's where we're coming in at. So when you have people involved in research, they co-create and they co-develop the research, and the whole emphasis is on collaboration. Now, you can be a study participant. Maybe from what I read anyway, you could be a study participant in that they could be using your research data, and you could be involved in a PPI group as well, but the two roles are completely different. You're involved in helping the researchers the whole way through the research process. It's using your lived experience to help to make the research relevant, as opposed to your data being used as as part of the data that's been collected and analysed. And that's really important. So I hope that's is clear, and I'm happy to take questions on that. And so what are the benefits of PPI? Well, the real benefits, you're bringing the lived experience of people to research. So that helps to keep the research more real and relevant. And it will also help keep the research going, and it'll help to disseminate the research, and it'll help to develop it maybe further research will emerge from research that, that's driven by patients. And people, patients and public can also bring other practical skills to research as well. But the big thing is that you don't have to have research skills. What you are bringing is your real life experience of living with kidney disease. And then what's the difference between patients and public? So another really valuable document is that same group that Carol mentioned, that the Health Research Charities Ireland group, they linked in with Trinity, and they developed a toolkit to help researchers who want to begin PPI relationships. And on page 10 of that document, they cite the HRB website. And in the HRB, they define public as meaning anyone in Ireland who has an interest in health and social care as a public service. And public includes potential users of a service. Whereas patients, they say, generally means people who use the service. So they would say patients, service users, clients, or their carers. And what they say is the important question that the charities and the researchers need to ask when they're looking at developing a PPI group is, who needs to be part of the PPI group in order to add value to this research process? So sometimes it might be people with a particular disorder, for example, that study on glomerular disease, or sometimes it might be particular cohort of patients, maybe a particular age or particular gender, or you know, in this study, they want people who have experienced living with end-stage living disease. In other studies, they may want carers. So really the important question is that what people do you need to be involved in order to add value to that particular research process? And the suggested answer that the toolkit gives is that it really can be people with experience of particular disease, symptom, treatment, experience, or a carer. It really depends on the particular study involved. So if we go to the next one, which is, where am I? So did I get them all? Hold on now. Where are you?
We're on slide 9.
Okay. Oh, did I miss slide 9? Yeah, slide 9. Yeah, so we can go to slide 10.
Okay.
So what they also say in the, I have a little typo there. It should be HRCI and Trinity Toolkit, page 13. What they say, the ideal PPI contributor is someone who has experience of their condition or other useful experiences and who is passionate, or somebody who has the time to devote to the PPI activities, and then somebody who can or is willing to communicate with the researcher and the research charity. So, you know, as I said, we don't need any background in research. And then when Carol asked me to look at this last summer, she sent me this in an email, and it was the IKA goals for PPI, and they were to ensure effective patient involvement in upcoming projects. And that's a really big, important thing as well, because the reality is, you know, for researchers to get a grant nowadays, they actually have to have a strong PPI element. And Zoom has decided to come back, but we stay where we are. And I said, even when I worked in UCD, we had to get patient and public involvement in the design of our curriculum, because you really want education also to be tailored to patients' needs. So it's really important that patient and public involvement is not just a tick box exercise as such. So that word effective is really, really important. And I think when you look at the current study, they really have thought seriously about the value that patients can add to their study. Another goal was that Carol wanted to review incoming requests for the IKA, for IKA support, and to make recommendations as to whether the IKA should support these. And this is something we will work on, Carol, won't we, going down the line? Yeah. And we'll get a more general PPI panel as such. And then she wanted to ensure that the IKA strategy is followed and developed. So if we go to the next slide, it's 12.
Yep.
Yeah. So that leads us on to why we're all here today. So down the line, and you know, in the ideal world, we would have done it first. We'd have developed a whole PPI panel and probably done a little bit of input on, you know, the research process and how you might be called to give input at different stages of research. But actually, we're very lucky, you know, in that there is already funding for substantial funding, a HRB grant for a secondary data analysis project. That's what the SDAP there is, was awarded to Dr. David Keane and a big team, but he's the lead researcher on it, and it will be the first comprehensive analysis of the burden of kidney failure in Ireland from and they'll be looking at from 2010 to 2020. And as I said, they will be looking at things like mortality statistics, the statistics on the number of quality years lost through end-stage kidney failure. And they will be looking at analysing data that has already been collected on kidney patients. I think they'll be looking at 2 different data sets, and they will be looking at the difference in outcomes in relation to different kidney diseases, in relation to sex. I'm not sure if they're looking at age, but I think they are looking at what's the third thing they're looking at? They'll tell you about it anyway. And so they would say that there's international figures to say that your predicted length of life is shortened if you have end-stage kidney disease in the international studies, and they want to look at at the factors. In Ireland, there's no statistics in relation to Ireland, and yet all this data has been collected, but it hasn't been used for research. So they feel the research outcomes from this project have the potential to be very useful in informing future health service planning for patients with end-stage kidney disease. And then as part of the patient and public involvement team, your input will influence the impact of it. And I really will leave it to David to tell you more about the particular study. But what they need from us now is a patient advisory group, a PAG. So with PPI, patient and public involvement, and what they need is a patient advisory group from us. So we'll go. Yeah, you have it moved on. Great. So when they were putting in the grant proposal, now the grant proposals are hundreds of pages long, and Lisa Mellon, Cathriona, who you might know, who was previously on the board, she was very involved in it, and I think she's still very much part of the study. We're coming in while the study really has been set and the objectives have been set and the research questions have been set, but it is good to know that Lisa was involved, because they do say in the ideal situation, the partnership should begin at the very, very beginning. So we're coming in now where they have their grant and they need this patient advisory group. So when they were putting in the grant, the IKA agreed to lead on the development of a nationally representative patient advisory group. And they were looking for between 6 and 10 patients, but they will go with 4 if that's what they have. They will go up what they have. And as I said, ideally they want patients, not carers. So Colin and myself, can't help them. And ideally they'd like kind of a bit of diversity, but as I said, they're happy to take, patient experience, whatever is available to them. The IKA have agreed to chair a biannual patient advisory group meetings, which would include representation from the project steering group. And then the patient advisory group is to provide guidance on all project activities, and also to lead the planning of a consultative event, which will probably be online for patients and others, to discuss the concerns and the potential benefits of using routinely collected data in research. And they hope that will open lines for more studies using already collected data, more studies on end-stage kidney disease. The patient advisory group is to lead the development of patient-facing outcomes or communication in relation to the project outcomes. So, and that would be, Cathriona, you already seem to have the experience of that, which would be fantastic. It's how do you communicate this? And as you say, how even a picture can tell different stories to different people. And then the patient advisory group is to develop a strategy for the evaluation of PPI activities. And that's really important, because if you go back to what Carol's objectives in the beginning, it's really important that they actually have to evaluate their PPI activities. And the impact of their PPI activities, and potentially they will be writing a publication based on that. So that's all really I thought of to if we go on to the next one, Carol. That was my kind of very brief. I didn't, as I said, I was a bit, I won't tell a lie, stressed in the beginning, a couple of, before, because thinking, my goodness, is this very complicated? But actually, when I spoke to David, really what they want is a group of people that, they will have those biannual meetings probably online, but even a group of people that they can send emails to say, look, we've just come across this. What are your views on that? And I think there'll be a lovely group to work with. So, thanks so much for attending after a busy day, and for listening. Apologies, my internet went. If you've happy to take questions. You might have to tell me, Carol, who's got hands up or whatever, because I'm just
right. Okay,
on the little mobile phone here.
Yeah, if you'd all like to unmute, and we'll have the opportunity now for you guys to ask questions about this. And David, Daniel, I know you have problems with your broadband, so I'll keep an eye out on the chat function if you want to put anything into chat, okay?
Hi, Carol, can you hear me now?
Yeah, we can, yeah.
Oh, brilliant, great. I just have one quick question. In terms of context, where does 100,000 euros get you when it comes to a research project? Like, is it a lot? Is it an adequate amount, or?
It's a lot, but you can never have enough. And I suppose I would defer to Jacqueline. She'd have much more experience in kind of budgets on research, but
yeah. Well, the budgets and research can be colossal, and I'm just trying to see, can I see what the actual budget for this one is? Research can cost a fortune, and that's why I think, rather than the IKA commissioning research as such, to be able to collaborate with experts in third level and in healthcare, and the National Renal Office is involved in this as well, to be able to collaborate with them, I think is really important. And I would hope maybe that as if we build up relationships, then we'll be able to partner with them and go for these big grants. I can't, I think you could wipe out a charity surplus very quickly if you're going to spend it all on research. But the big thing is to collaborate. And do you know what? You won't get research grants without collaboration, and you won't be able to do research without collaboration. So I do think collaborating and getting involved is the way forward.
Yeah. Okay. Perfect. Thank you.
Right. Any other questions?
I mean, this study is great, and I swore I wouldn't talk about, but they have built-in money for PPI within this study, and I'll let you deal with that later on, Carol.
Okay, great. Okay, well, David is in the waiting room, so is it okay if I admit him now, unless anybody has any questions? Okay.
Yeah.
Right.
And I might try, Carol, to get back in and do. So just keep an eye out for me in the waiting room.
Okay, I will indeed. Right. Hi, David. How are you?
Hello.
Can you hear us?
Yeah, I can. I'm on now. How's everyone?
We're grand. We had a small gathering, so we started a little bit late. We lost a few people due to internet connections. Daniel had to go in and out, and then Jacqueline, who was just about to present when her internet went down. But thankfully, I just moved on her slides and you came back in on mobile. So she might disappear for a couple of minutes. And
yeah, we're used to that now, I think.
Yeah.
The internet's still being bold.
So I've got 5 kids pottering around behind the door somewhere, so there could be a chaos at this end too, very possibly.
All right, fair enough.
And I've 2 dogs wrestling below.
Yeah, very good.
Yeah. So we've given you an introduction, and what we have here at the moment, you know, Jacqueline, of course, Cathriona Charles is on our board, and she's participated previously in PPI, so she's great insights. And Rachel is one of our peer support volunteers, and she was recently transplanted, and she's also one of our branch officers. And then we have Daniel O'Connell, who's having trouble with his internet, so he's been in and out. So I'll hand over to you, and if you want to kick off.
Okay, thanks very much for joining as well. So my name's David Keane. I'm a bit of an oddity, I guess, from a professional perspective in the renal unit. I was a clinical scientist in the NHS for 15 years. So I sat in the middle of a dialysis unit, and there's not many of us knocking around, but I was kind of responsible for a lot of the data management, so managing the clinical data, which obviously has a lot of relevance to this project, but also kind of lots of interest around fluid management. So I was making measurements on patients a lot to set their target weights and work with them to achieve their target weights. So measurements like blood volume measurements and bioimpedance measurements. So very familiar, although I'm not a medic, I don't have a doctor's background. I am very familiar with life on a dialysis unit, and and across the kidney disease spectrum I was involved in Leeds. So I moved over to Galway about 18 months ago, and primarily I work with a medical devices centre here, but my kind of passion is in kidney disease, so I'm trying to get as many grants and work in this area as possible to kind of go back to where I was in the UK. So I guess that brings us on. Let me just share my screen. I always get mixed up with Zoom and Teams, so tell me if this looks right. So if I
it's coming up.
Turn this into presentation. Do you have it full screen now?
Yeah.
Super. So this is a project we applied for, it feels like quite a while ago now. The project officially started in December. The fancy title and it is in front of you, but I think the first job of the PAG group when we get set up is to kind of think of a better title, I think, for the project to take forward. So I'm going to just talk a little bit about the project, just a small amount, not a huge amount. I realized when I was kind of putting the slides together that this might kind of stimulate lots of questions, and I suppose at this point, given what I know from today's meeting, this is really about more about the PPI and setting up the PAG group. So I suppose I'm happy to take any questions at all now, but I think what I hope is that when we really form the PAG group and we actually set up a meeting that's really focused on the project rather than setting up of the PAG, we can really tackle some of the things that may be worth discussing in a bit more detail. But we'll go through it and see what it throws up. So first thing to point out, I think when I came over, I didn't really know many people around the country, and we were very keen to try and make this as inclusive as possible across the country. I know what medics' egos are like, and I didn't want to offend anyone. So we went around the country and tried to get representation from all around the country, and I think we did pretty well there. You can see the hospitals and universities and professional bodies and societies all involved in the project. And the project is known as an SDAP, so that's a secondary data analysis project. It's funded by the HRB. And just very briefly to kind of just think about the basis of what we're doing here, this is a little bit different than a lot of research studies because the data that we're using, we're not collecting as part of the research. So it's actually one of the strict criteria from the HRB to fund this is that you were absolutely not allowed to collect any new data whatsoever. So this has to be data that already exists, and it exists for clinical purposes. So all the data we're using was entered into the renal clinical information system, not for research, not to answer an academic question, but actually to support patients' care. So that's the fundamental difference between the secondary data analysis and the research data, which we collect specifically to answer a research question, a hypothesis. The staff, the data is entered into the information system by clinical staff. So this could be nurses, physios, dietitians, doctors, admin staff, as opposed to researchers or academics. A big thing is consent. So when we do research, we have to take informed consent, and part of that process is allowing us to use the data that we collect in research to answer the research question. It's a little bit more complicated with secondary data analysis. We don't need consent to use the data for clinical care. So we don't need explicit consent for this. So we can use the data that's on that system to help guide how we care for the patients. But actually, when we want to use the data for research, we do generally need consent. This becomes quite challenging, and it's a topic of ongoing conversation in a national level here about how we deal with this. At the minute, it's actually, it's not feasible to collect consent for everyone who's on our clinical information system, that's EMED. So you have to go to a committee and you have to make some arguments why your research is for the public good and why it's unfeasible for you to be able to collect explicit consent. And then you get what they call a health research consent declaration committee waiver, I think is what it's called. So that's what we've done for this project. It's also important to kind of realize that the quality and the coverage of the data is very different. When you're doing a research subject, a research study, you have people entering the data, you have people checking and double checking and triple checking the data. You don't have that for the amount of information that goes in clinically. So you can get variable coverage and variable accuracy. But on the other hand, where, something that's really important is that a lot of the research we do ends up being on a small number of patients, often isn't particularly representative of the wider patient population. So a good example of this would be that most research studies exclude patients who are unable to read and write in the English language. So you end up excluding significant minority groups, and this isn't good when we try and then generalize our research, so apply our findings back to the population. So this might, historically, there's really big examples where some drugs or some treatments were tested, say, only on men, and no women were involved in the studies, and then you try and apply the results of the research and give some drugs out to men and women, and obviously the effects can differ greatly, so you can't generalize the results. So there's quite significant differences there between the research data and between the routinely collected data, where we have effectively wide coverage, real world setting of people, and it's much easier to generalize results. So that's kind of all the background we're going to go into. Then, so the HRB opened this call. We wanted to put an application in. We wanted to be open about how we generated the research questions. So we asked the Irish Nephrology Society Research Committee to solicit research questions. These were scored by the National Renal Office and by the IKA, and then the preferred question was used in the application. We then made use of all the infrastructure that exists in Ireland for routinely collected healthcare data. So I'm not sure how familiar you are with this kind of area, but EMED is it's Island of Ireland database. So all patients who have renal failure are entered into EMED nationally, and this will collect data from the labs, from dialysis machines, from clinics, and it's all stored in one database. So it's a really great repository, actually. Where I used to work in the UK, you'd have dozens and dozens of different separate databases across the country for all of the different centres. So it became a lot more difficult to look at a national picture like we're trying to do here. You have a programme of work out of Limerick called the National Kidney Disease Surveillance System. That's Professor Austin Stack's leading that. And they're doing an awful lot of work and have done for quite a long time in this area, looking at trying to use this data to get some information. They've done some really nice work around things like vascular access and anemia. things like that. And then there's a transplant registry, which is a really well-kept, accurate, up-to-date registry of everyone who's had a kidney transplant in Ireland. So these are the data sets that we're going to use in research. And then one of the big things the funder wants to see from this project is that we have what they call knowledge translation. So this means that we don't just get some results that are academically interesting, but that we actually make sure that the results are useful to what they call knowledge users. So that would be people like the IKA, the National Renal Office, and the Irish Nephrology Society. So that would be helping to inform and hopefully improve patient care. Okay, so the data, you know, I talked a little bit about the consent. So just to describe the kind of flow of data for the research, we'll have routinely collected data from the nurses and the doctors put into the EMED database. This is all part of routine clinical care. We're also getting some data on mortality. So we're using the central death register. So we're picking up that information, and we're taking the EMED data and the Central Statistics Office data, and some of Professor Stack's team in Limerick are going to extract this data, and they've got established techniques under their health research, their consent waiver, effectively to completely anonymize the data before it comes to the University of Galway, where we're going to do the analysis. So when we get the data, there'll be absolutely no patient identifiable information at all. So that's part of the consent waiver process. The objectives of the study. So what we want to do, we realize that actually there's never really been good analysis of mortality rates for patients and people with kidney disease in Ireland. So it's written down as burden, and I'll come on to talk about that in a minute why, but effectively we're measuring some estimates of the effect of the health condition on people who have kidney failure, and we're measuring the rates of survival, and then we're going to compare that to international data that's already been done to try and benchmark how the care in Ireland compares to other countries. The second thing we're going to do, and this really focused on something that the National Renal Office are very, very keen to develop, which is a big part of their remit is trying to plan for the future around where they can build dialysis centres, where is the need for capacity. And so what we have here is called a multi-state model, but effectively this is just a fancy statistical way of trying to project into the near future, so over the next 10, 20, 30 years, to try and get an idea of, based on what we know at the minute about how often patients move from CKD into transplant, into dialysis, and between the different states, to try and predict how many patients are going to need dialysis in the different regions of the country and what the transplant rates might look like. And then the third stated objective is around dissemination and translation of knowledge. So this is, again, comes back to this point of making sure the information and the data that we get out of this study is actually useful to people. So the first objective is around survival. So we're comparing it to 3 different sources of information. The first one is called Global Burden of Disease. This is a World Health Organization ran project, and this is where the idea of burden comes from. So this doesn't just look at survival and mortality, but it actually does some analyses where it gives some weightings to different health conditions. So everything from having a broken leg to maybe having bipolar disorder to having diabetes or having kidney disease and being on dialysis. And it basically tries to compare the effect that the different conditions would have on somebody's quality of life. And so it measures the amount of time you live with a health condition, and also measures typically compared to the life expectancy of somebody without kidney disease, how long is someone with kidney disease going to live? And it kind of brings them together into a value of what they call disability adjusted life years. And we'll measure that and we'll compare that to lots of countries around the world. We'll then do some analysis comparing to the United States renal data system. They have a really good data set and they measure death rates, and we'll replicate what they're doing and compare them. And then in Europe, in EU, they have the European registry where they measure 1 and 3 and 5 year survival probability. So this would be say for a transplant patient and a dialysis patient, what's the percentage chance that an individual on dialysis or with a transplant is going to be alive in 1, 3 and 5 years time. So that's the kind of first objective. We'll do the analyses and we'll kind of benchmark against the international comparators. The second one, as I mentioned, is effectively a model where we estimate from the data that we have at the minute how many people are going from CKD4 state to have dialysis. We do have patients who go from dialysis and have recovered function and go back into CKD4, so we'll measure that. We know our death rates. We know how many people are going to have a transplant from dialysis or straight from CKD to have a preemptive one. So we can work out all these probabilities and then run a model will help us predict where patients are going to be over the next decade or few decades. And we'll do this with the National Renal Office. And then the third objective is around knowledge translation and dissemination. So there's the academic publications and presentations. We want to influence practice, so generate evidence to support doctors and nurses working in this area. We want to do, and this will be where the patient advisory group really comes in, some patient-facing communication so that we get appropriate information out to patients. We want to support the National Renal Office, and we also want to support the use of this data to feed into the European registry, which we just mentioned, because this map you can see here demonstrates all the countries that are feeding data into the European registry. And you can see Ireland here is one of the few countries that doesn't put data in there. And we feel that it's something that we should be trying to progress and hope that this project will support that. Okay, that's the project. I tried to, condense it down as much as I could. I probably didn't do the best job, but there we are. That's the background, and we'll have lots more chance to talk about that. Just onto the PPI part then. This is what we said we'd do in our application. We said we would develop a patient advisory group. We said we would hold a patient consultation event. So the difference there would be the PAG group, I hope, will be working with me and the wider research team over the next 2 years throughout the research study on a continuous basis to try and influence the research. The patient consultation event is a one-off event where we want to really learn, rather than doing PPI, we want to learn from the patients what their perspective is on the use of their data. We're acutely aware that, we are doing this without explicit consent, as I mentioned before. So we want to make sure that we really understand patients' concerns or hopes or whatever it may be for this type of work. We want to develop patient-facing communication, dissemination, so whether that's newsletters, animations, posters, whatever that might be. And we want to try and evaluate the impact of PPI on our project, because I've done PPI work a number of times previously in the UK, and often we get to the end of the project and people ask us to evaluate how PPI has impacted our project. And it's actually very difficult to do that when you're looking backwards. It's easy to say, oh, things went well and, it was great and it really influenced how we, developed and delivered the research. But actually, if you don't really think about it at the outset, how you're going to try and measure that and demonstrate it, it's difficult to do looking backwards. So we want to try and develop a plan to somehow measure, it's difficult to do, but somehow measure the impact of PPI on the project. And in terms of support for the PPI work, I work in Curam. It's a Centre for Research in Medical Devices based in Galway, but it's a national research centre, and they have an amazing PPI team who do really fantastic work in this area, and they're supporting, obviously the IKA are crucial to this, and we also have support from PPI Ignite, who've been very helpful in getting us to this part so far. So the PAG, this is kind of how what I have experienced in the past working well, this kind of model. So in the PPI work I've done in the past, it's clear that individual people living with kidney disease can, things can happen. It can be hard for them to have a sustained input into the project. We don't want people to feel like that shouldn't mean they get involved. What we've felt works well in the past is to have some PAG leads. So these are people who are a little bit more professional, maybe involved in an organization like the IKA. So they can have paid roles to be liaison between the study and the individual patient advisory group members. So they would be kind of the central people feeding information back and forth from the main study and from the patient advisory group. So I think we're very lucky in this case. We've got Jacqueline and Colin who are going to be acting as the leads there, supporting the PAG group. And then what we want then is to develop somewhere between 6 to 10 individual PAG members. These people could be anywhere in the country. They could have, different relationships with kidney failure. So maybe they are somebody who's lived through it, maybe has a transplant now, maybe is on dialysis, maybe has a loved one who's had kidney failure and is working in that sort of role. All we really want is people who have got real lived experience of kidney failure to give us honest opinions about what it's like for people who are living with kidney failure, rather than us researchers who are thinking with a very different lens. So that's the kind of requirements we have. There's nothing more than that. People who are interested in getting involved. The more people want to question us, tell us we're wrong, tell us that we should be doing it a different way, the better. So we want people who want to really speak up and tell us their feelings. But really, there's no other requirement for the people who are going to be involved in this. We're going to run the PAG group really. We'll have meetings. Maybe we can define this when we get going, but we're thinking maybe 6 monthly, where we'll have a full review of how the project's going and frank discussions. And then in between times, we hope to be able to use email or other communications to use the PAG group to answer simple questions. So one thing I might do, once we get going, is to start to email out some ideas about a name for the project, which is what we started with here, a name that doesn't really perhaps represent what we're doing. Maybe we can come up with a better name or think about what the name elicits for patients when they see it. So that's the PAG group. And then just in terms of how it feeds into everyone else working on the project, we've got a project steering group, which involves individuals from all the organisations you've seen on the first slide. So these will meet with this group maybe 3 monthly. Now, this steering group will be open to anyone who's a PAG member as well. We don't expect them to have to come to all the meetings, but if they choose, they would like to come and sit on those steering group meetings, they're more than welcome. And we'll hope for at least one member of the PAG leads to come and join us to provide feedback from the patient advisory group right directly into the steering group. And then we also have the knowledge translation group, who are really going to work on these things that we talked about, making sure that the research is really grounded in what the community needs and wants. And then we have a data management group this is the boffins really, who are going to sit down and really do all the hard statistical analyses. So that's what it kind of looks like. And that's how we're working to manage the project at the minute. And that's it. So I thought I wasn't going to talk for very long. I think I've talked for longer than I was going to. But I guess to finish off, just to say, I'm absolutely more than happy to answer any questions now or after the event. But really, what we really want to work towards now is having people put their hand up, signing up to the PAG group, and from there we'll start to set up some communications and plan our meetings and see how we can make this work best. Okay.
Great. Thanks, David, for a really clear and overview of the project. And as I say, the more I hear about this project, the more I think this, when we have this data, it would be so brilliant for our campaigning. And it's just great that you know you're serious about the patient involvement in it. So I'm going to ask if people want to unmute their mics, and if they have questions or specific queries, now's the time while we have David here to ask them. So I'll ask, maybe kick it off. In terms of the research, how would you see the data being presented? Like, is it going to be saying, in comparison to other countries, this is how kidney patients are doing in Irish treatment systems?
Yeah, so there's the three analyses we're gonna look at. The first one is the global burden of disease, and this is the one that's, you know, in theory should provide a little bit more comprehensive information, because it's not completely focused on mortality. It's also focused on how long someone lives with a condition. So, for example, it might say, you know, say somebody at the age of 20 ends up on dialysis, spends 5 years on dialysis, then gets a transplant, lives for 40 years with the transplant, and then ends up on dialysis for a couple of years before perhaps passing away. You know, it would measure that whole time period, and it applies these weight to the amount of time. So effectively measures not just how long, how much life was shortened for that individual. So maybe they died at 60 and the life expectancy for someone in Ireland is 65. So you would say that they've lost 5 years of life compared to somebody without the health condition. But then it adds up all those 40 years or whatever where somebody's been living with this health condition, and it adds that into the mix and provides these values. Now, as we've been looking at this data more and more, it does have data for every country in the world. So we will be able to actually compare to pretty much anywhere in the world. And I was even looking in the UK, where I used to live, they even break it down into regions. So you can even go into regions in the UK. But to be honest, when we started to look down, I think there's quite a bit of, you know, extrapolating from one region to another. So we really need to do a bit of work to understand where the data comes from. So, for example, there's lots of data around life expectancy in Ireland, but it's not clear to us right now where they've got that data from, if it's actually from Irish data or whether they've just looked at other countries in Europe and kind of looked at different factors that might influence it and made some estimates. But we will have the data that we'll be able to compare to effectively any other country in the world for that stuff. For the US renal data systems, that's fairly straightforward looking. It comes out, they present it as a death rate, they call it. So they will say dialysis patients in America, for every X number of patient years, there will be X number of deaths. So 62 deaths per 100,000 patient years or whatever it is. So we will generate the same figures, and then we will be able to directly compare it to US data. And we'll look at it by centres in Ireland. We'll look at it by transplant and dialysis. So it's pretty basic data, but we've never had it before. So actually it will hopefully give us some reassuring data that actually we're doing okay. But if it does flag up something that maybe transplant survival isn't so good and dialysis survival is good, then that gives us a signal as to think about, why is this happening? What can we do about it? And then the same, so for the ERA, it'll be the European data, they present it as this percentage survival. So this is the chance that somebody on dialysis in Ireland is going to be alive. So it might be a 92% chance that somebody is going to be alive in 3 years or whatever it may be. And again, we'll break that down by centre. And even one thing we're trying to do is look at different things like primary renal disease. So whether it's diabetic cause or hypertension or whatever else it may be, to try and give us an idea of comparisons, and then we can and we can look at them directly compared again to all the different European countries. So I suppose it's benchmarking is one of the ways of looking at it. Yeah.
It's interesting you're benchmarking centres and that they agreed to that. You know, I guess it's great. You might find that Galway as a centre, you know, has better figures, and give you then what are they doing there that's better than everywhere else. But I guess I'm surprised centres aren't afraid that maybe the show up has been less.
It's funny because there's always the instinct to think in that way, and I think when Professor Austin Stack's done this in the past, he's numbered the centres, so he calls them 1 to 6 or whatever. He doesn't give them their full name, and I think we'll have to work with the clinical teams about whether they're happy for us to do this. But I think the way outside this project, all the talk around a registry, I think it's really important to be open about this stuff, because that's how you improve care. And we did a lot of work in our centre in Leeds where we actually named individual dialysis units and consultants even. So we tracked lots of data over time for patients under the care of different consultants. And actually what there was caution at the start, but actually what you see is, okay, some consultants may prescribe different types of, phosphate binders, and some may be more liberal and some might not, and there's reasons for that. But when you start to see the differences and think about why there are differences, that's where you highlight areas that you can make improvements. So I understand why people can be worried about being really open about the different centres, but if we find that one centre does have consistently poorer figures than elsewhere, we really need to understand why. And it's not, it's about doing this in an open fashion and not pointing a finger, but actually saying what's different here and what's going on here that's different. Maybe the population's different, maybe the staffing levels are different, maybe it's something else, the types of patient they have there are different. And if we can understand that, then that will help the National Renal Office plan to try and address the things that are different there and try and bring them up. There's also the obvious opposite, where you have somebody who's really good, a centre who's really, really good, and you can go, okay, well, what are they doing there? And let's mimic their practice elsewhere.
Or what's their population?
Sorry, you're breaking up there, Jacqueline. Yeah, I mean, what we agreed, David, when we're doing the a survey of patient experiences in the healthcare system, and what we agreed, we're doing it in partnership with the NRO, and it was quite a complex process. And so what we agreed was we're collecting data by centre, but that won't be published in the public report. It will be available to the NRO. We will share it, but the data will be anonymized in the main public report. And it's interesting, and this is where this study could be very useful, because as you say, when you look at the UK, and we would do this on the transplant side, you drill right down into individual hospitals, and you can see where a transplant didn't take place because of the lack of an ICU bed. But we can't even get transplant figures on an ongoing basis. Like, I have practically to beg the NRO to give me the transplant figures, and I get them on the 29th of December. They'll tell me how many donors there have been, but they will not tell me, or deceased donors, not even living donors. But until the end of the year, and they're about to publish figures, we can't get hold of them. So there's a real culture of, holding things in. And again, I think part of it is the blame culture that has emerged, that if there's one centre doing less well than another centre, it's kind of, instead of saying, like you've just said, let's understand why, they could be dealing with more complex patients. you know, there's a blame culture. So I think that's going to be a big part of the process of making sure this information is useful. And I think patients can really drive getting this information out there, because obviously we have a vested interest in getting it out there. And all the research shows that once you start doing these comparisons, it drives change. Because doctors, when they see the data, they think, oh, what's going on? And as you mentioned, the egos, you know, that can be a real force for change, and can be interesting. And in terms of involvement, I don't think it's really all that onerous, the 6 monthly meetings and then responding to emails. And when emails come in, what's your expectation of a response time?
I wouldn't have, you know, I wouldn't have huge expectations on people. You know, I know people are volunteering to give up their time. So, you know, if I need something very quickly, it's unlikely, but if I needed an answer very quickly, I'd make this clear. But I think, you know, for most things, we can discuss them in a meeting. But it might be that there's some communication. You know, we've got a great chap in Kuram working on trying to develop a website for us, and just to try and maybe do some newsletters. So it might be things like, there's a draft of a newsletter coming out, just send it around, see if people thinks it reads okay from the perspective of a PAG member, and just to feedback any comments. So there wouldn't be anything too onerous at all. One thing I did say I'd do for you, Carol, which I half did, and then I think this meeting snuck up on me actually, was to do a really brief kind of one page, and I've got it. It's about 90% done, so I'll finish it tomorrow and send it around. It might be something you could, you know, send out in communications to try and drum up some interest, because it's just it kind of says, this is what we expect, this is what the is, this is what we'd expect, this is what the project's about, and it's only one page and really simple. So I'll get that to you tomorrow. But yeah, it would, you know, it won't be a huge task, and it's something that, you know, if somebody's not feeling very well on the meeting and they can't make it, that's fine. And that's why we try and get, you know, numbers, like if we can get 6 to 10 people, then it makes it easier that there'll always be a decent number of people attending and somebody to kind of respond to queries.
Hey, Daniel, you have a question? You have your hand up. You need to unmute yourself.
Yeah, hi Dave, how are you? Just
Hi,
in regards to the data that you're going to collect, like how deep are you going to go? Like, because what you said there, I found it fascinating in terms of, you know, one consultant could prescribe Renagel in terms of a binder over another one, say in Beaumont, compared to down to University Hospital Waterford. Like, how deep down are you going to go in terms of the patient themselves, and, you know, and age, sex, medication, lifestyle, cause? Like, how deep are you going to go in terms of the research that you want to get, and in terms of, are you limited in the research that you can eventually publish? Because I found that what you said there, like, is really interesting in terms of, you know, if you had 2 males in their 30s, they have the same primary cause of renal failure, and one was on a separate tablet to the other, you know, and one graft lasted longer to the other, like, what was the primary cause of failure and things like that? Was it down to diet? Was it down to lifestyle? Was it down to the medication that they were on? So basically what I'm asking is, in terms of how much research can you collect and how much can you actually give back in terms of the outcomes?
So this project, the answer is not much. So the only data we're going to take out of the system is age, sex, primary renal diagnosis, and the kind of patient timelines. That would be when they first went on dialysis, if they had a transplant, if the transplant failed, they went back on dialysis. So the kind of events in the modality shifts, and that's it. That's all we'll have. And the center, that's all we'll have for this analysis. So the stuff I was talking about, I guess, is kind of where I'd love to go. And actually, you know, Carol, be aware there's lots of talk at the minute about a registry, developing a registry in Ireland. And, you know, the functionality that a lot of people want from the registry is the kind of stuff, Carol, you were talking about, you know, how many transplants and how many people put on dialysis and all that stuff, which is obviously really necessary. But I really strongly feel that having the data and that registry set up in such a way that enables people to do, and actually it wouldn't formally, in many cases, come under research. If you're looking at the data to help improve your practice, it comes under audit and quality improvement, which makes it a lot easier to do. You don't have to get the same approvals and consent processes. So the example that I was given, and seems to be what you're talking about, is kind of what we had set up in Leeds, where every 3 months we'd all sit around a table and we'd have, you know, basically charts of all the patients, how many, you know, MSSA infections they had in each of the centres, you know, how many patients are on less than 3 times a week dialysis, how many patients are on a sodium of 137 versus a higher sodium. And it's just looking at practice, really, and it does start to highlight where particular centres or particular doctors or particular patient groups are doing differently. So it can be better, it can be worse. And, you know, there's quite a lot of times when stuff came up in those sessions which triggered things. I don't know, maybe the water quality in one dialysis unit was bad in one case. So that's where I'd love for this kind of work to go. So it's not just, and you can do the big research questions, maybe like you talked about, to say, okay, how do patients who are on certain medications, how long do their transplants last compared to somebody else? But there's also that other bit which is less kind of, research is always given a lot more weight and a lot more prestige in healthcare than the nitty-gritty work of quality improvement and audit, which is basically just checking practice and seeing how everyone's doing and trying to look for flags of where things are good or not so good. So I think, you know, if we can get the registry up and running and working in the best possible way, it should facilitate all these things. But I think, you know, it's a big task, and there's a lot of people who have their own say on how this should be done. So, you know, there'll probably be a lot of conversation.
Everyone has their own agenda.
Yeah. But to answer your question, for this project, we're not going anywhere near. We're going to centre level and you know, different sex and PRD, the primary renal diagnosis. That's about it.
Perfect. Great. Thank you.
Right. Rachel?
It's not really a question, I suppose. It's just to make a point that if you're going down to like the centre level, like I'm a teacher and my school scores consistently high on the school league tables, but every year they come out, all of us teachers in the staff room resent them coming out because we just hate them. So you might find you get that kind of same thing from the healthcare workers.
Yeah, absolutely. And I think, so my wife's a teacher, so I you know, she resents those league tables as well massively. But I think maybe, you know, from my perspective, with the league tables in teaching, I don't see much learning coming out of those. So it comes back to that point again. It often feels like, you know, you're just trying to flag up schools who aren't doing very well, or, you know, to put more pressure on them. But if you can frame it, I think, where you're really just trying to learn how things are doing at different centres. But yeah, I mean, I completely take your point. We, particularly the nurses in our units, used to really worry that they were going to get blamed if things weren't going so well. So it may be coming back to, like Carol said, that it's about anonymizing it in particular forums so that it's not named and put out into the public and just looked at in groups where we can actually do something about it. I think the centre thing is really necessary for the second part of the analyses. We're talking about the model where we're trying to look at projecting populations, and that's not really about quality of care, but that's really what the NRO want to see, because what they want to know is, you know, is the number of people who need dialysis maybe in the Midlands gonna, you know, keep going up and up and up, and then they can look at their provision for the number of dialysis stations they have in the Midlands, and they can maybe go, do you know what, the next dialysis unit we're gonna build needs to be somewhere out in the Midlands rather than in Dublin, or it needs to be up in the Northwest or wherever it is. So for that stuff, I think we definitely need the centre.
Okay, yeah, that's fine. There's just like wanted to make that point.
Yeah.
I think the contrast, and this is where I think the NRO are very strong, is that they want to use it as a learning exercise, not as a beat you over the head exercise. And we'd obviously be in the same camp that it has to be part of a learning exercise. And it is interesting in the healthcare system generally, like, you know, I'm surprised when I come into the IKA how little data there is. And we've had to put a huge effort, and we're still nowhere near it. We're depending on outsiders to generate data for us. That means we don't get the funding or the attention, that kidney treatment deserves. But there is the National Office of Clinical Audit, NOCA, which some of you will have heard of, and what they bring is it's a separate agency. I think it's part of it's funded by the HSE, but I've never been able to find out their exact autonomy. But what they do is bring a real rigor to measurements. So they do things like they audit the ICU, the use of ICU beds, and what are the outcomes in ICU beds. So they bring a real rigor, and it's accepted, and all of those reports are published. So we were part of a campaign to get funding for them to do it on the transplant side. So on the organ donation side. So it was just announced. It hasn't been announced, but we know that funding for a national audit of organ donation will now be expanded to all the main hospitals, which is great. But we want that to be expanded to the donation side. But we also wanted that rigor to be applied to the whole kidney treatment service. So they do it on stuff like strokes as well. But there's nothing really for kidneys. So this data will kind of help us inform the need for that. And we've managed to work out, thanks to AstraZeneca, actually, the cost, the firm cost of what the HSE is, the cost of kidney disease. And we're using that data to drive the case for screening for chronic kidney disease and including it in the chronic disease treatment programs. So none of this is going to be a magic bullet, but what we can do is working on it is changing the culture around data and the use of data to drive change. And that's what's missing in the healthcare system. And, patients need to be at the center of this. And that's why it's so important we get involved in this. Right. So from our point of view, we had hoped, David, to have a few more people on this, but technology and people's lives, and people get sick, and like even Colin is sick this evening, means we didn't have as many. So it's great to have the slides and to have the video recording. And what we'll do is we'll circulate it, and we're not asking, and obviously it's Cathriona, Rachel and Daniel to make a commitment tonight to this. What we do is we circulate it, and then we'll set a date for people to come back to us, and we'll circulate it widely for people to come back to us and indicate an interest in participating in this group. And if you send on that what's expected of you, that would be really helpful, because
I'll do that in the morning.
There is a lot of interest in this. Does that sound reasonable?
Super. Yeah.
Okay, that's great. So I won't do the feedback poll because we've so few people here. So unless anybody has any questions or wants to add anything, we'll finish on time at 8 o'clock.
No,
Great.
just thanks to everybody, and hope to see you on the PAG. And David, thanks for your time, and hope the kids are house isn't destroyed with the kids outside.
Yeah, they've been sneaking around, but I don't think they've been causing too much noise.
No, we didn't hear them. So again, we appreciate you meeting us in the evening as well, because
no problem.
It is a big commitment, and certainly I'm really looking forward. I won't be as involved in the day today, but I'm really looking forward to seeing this project happen, and I think we could really work well with you. So delighted to be part of this.
Great, fantastic.
Okay. Thanks, folks.
Right, thanks a million.
Bye. Bye.
Thanks. Bye-bye.
Okay,
Bye.
thanks everyone.
Thanks,
Good
Daniel.
night.
Thanks,
See you the next
Rachel.
time.
Thanks, Cathriona.
Bye bye.
Okay, bye.